Great. I've been reflecting a lot since I've been here, and I haven't caught the whole day, but I feel as though I need to give a different talk than the one that I thought I would give. I realize now that I think I am here to bring up the very low-tech end of the spectrum of the future of pharmacy discussion that we're having. I think that, well, a couple things that come to mind. One is, I promise you, I vow to you today, there will never be an app for pharmacy. Our profession will only move forward and be successful, and we will only find our place and advance our place in the care of our patients as our clinical skills in looking after them and making difficult judgments about what our patients need and what solutions we can provide for them to improve their health and make excellent drug therapy decisions for them. So don't worry about needing an app for that. If there ever is one, it will not be on Android phones. It will only be on iPhones, hopefully. It's always good to try to alienate at least 40% of the people in every room. And so I love you, Android people. I love you. Less so your phones. Other things that I'm reflecting on right in this moment, I was grateful when Andre did an unbelievable thing, which was in a health tech panel, found a way to make the Canada Post snail mail system be an agent of innovation as the conduit for his medical marijuana. And so, that's very true. That's where I get my marijuana that way as well. I didn't put the medical part in there. And so I spend most of my time thinking about and talking about and helping pharmacists and people who are becoming pharmacists advance their clinical skills, assessing patients and making drug therapy decisions that are in their interest, and then helping them figure out how to follow that up and ultimately what good drug therapy for our patients looks like. And so when you look at a topic title like the one that we have here, I feel like what it depends on more than anything are those extremely low-tech aspects of being a professional. And so what the things that we'll talk about today are technologies. They are thought technologies. One way of thinking about the other technology stuff that we've been talking about so far today, a lot of those things, I'm learning new acronyms like mHealth. These are ways of, a lot of you are engaging in mHealth right now as you text people you love and help them figure out whether your kid at home should be, taking that next dose of acetaminophen or whatever. And that's mHealth. What a lot of these technologies enable us to do is to extend that clinical skill that we as professionals have and bring, extend that further. So reach patients more conveniently, more efficiently deliver the care that we have to provide, the care that we have the skill to provide. Do that in ways that are more acceptable to our patients, that sort of thing. And so what I want to just spend a couple minutes making some remarks and reflections about are these low-tech things that have to do with our skills as clinicians and actually knowing what things our patients need from us and monitoring them accordingly. So let's start thinking about a patient. Now, so the only pharmacists who spend their Saturdays doing what you're doing today are the outstanding pharmacists. All the pharmacists who most need to be thinking about the things that we're talking about here this weekend are not here. You are people who, those of you who have a patient care role, are people who monitor your patients. You care about your patients. You're in the business of identifying what their health-related needs are and their drug therapy needs are and optimizing their care and following up and monitoring them. And I very much appreciate that and understand that. My hope is that there is maybe one thing that comes up in the next 20 minutes that you feel like is something that might be useful to you, probably as a thought technology, meaning a way of thinking about the things that you do. And so my challenge is maybe by the time we're done here, Be able to tell yourself, what one thing might I do in my practice that's different from what I did all of over the past week, based on what we talk about. So, let's just ground our discussion. This is JN. He's a 73-year-old male. He presents to our community practice today. And what he's telling us about is that he's been feeling dizzy when he goes from lying to standing. And he almost fainted this morning when he did that. We know that he has a past medical history that includes heart failure. He has systolic dysfunction. He has an ejection fraction of 30%. And he had last had an echo a year ago. He had an MI 7 years ago. Hasn't had any angina since then. And the history of this illness is that his furosemide dose for his heart failure got increased from 40 milligrams in the morning to 60 milligrams in the morning 2 weeks ago, in response to his having had several episodes of peripheral edema, pedal edema. And his exercise tolerance had been reduced over the recent days. And the patient does associate this dizziness that he's experiencing and telling you about today with this furosemide dose change. But he's worried because he knows how many weeks or months it takes to get an appointment with his cardiologist, and his GP is not super confident about what would happen there, and he's concerned. And so this is before you. And as all pharmacists do, we will assess our patient. We will form a synthesis as to what we think is going on with our patient. We are thinking about what possible solutions exist and what actions we might take. And only then, of course, are we interested in how we might monitor those actions that we take. We know that this guy takes his he's on ramipril 10 milligrams a day. He's on bisoprolol 10 milligrams a day. He's on furosemide 60 a day. As I said, he takes aspirin 81 milligrams a day. And he's on atorvastatin 10 milligrams a day, has no known drug allergies. And we assess him from an adherence point of view, and our sense is that he probably takes these medications. And some of our synthesis about this is that this is a person who's on pretty contemporary, evidence-based systolic dysfunction, mortality-reducing heart failure therapy. Obviously, this is what we do when we assess patients. We compare what therapy they're on to what our skill, knowledge, and understanding about what optimal drug therapy for someone who is how this person looks like. And so he's a bright, and he's ambulating independently. We decide not to do a complete physical assessment on him at the moment. And our sense is that this is a person who, based on a whole bunch of assessments that we do, which I'll gloss over for brevity, but you can read all about this case, which is a real patient that I know, in the Certified Pharmacist Prescribing Initiative draft framework, and all the details are there that you can look at. So we do a number of assessments on this person, and we decide that this is a person who, in our estimation, is experiencing, as you've all figured out already, hypovolemia that is iatrogenic. It's because he's being overdiuresed. His furosemide dose is too high, it would appear. He's now becoming symptomatic of that. That's putting him at risk for falls. And he's already telling us that he's experiencing dizziness, which, if we continue on the current course, is likely to become more severe. He also teaches us that he's become more adherent to his less than 3 grams a day dietary salt restriction diet, which patients like this are generally on some version of. And so because of his outstanding adherence, he's getting sicker, thanks to us as people who are providing him with drug therapy. And he's cognitively intact, and we start talking to him about the possibility that he doesn't need to go through life bouncing between being hypovolemic and dizzy and hypervolemic or excess extracellular fluid and pedal edema and possibly pulmonary edema, not being able to put his shoes on, but that we could teach him to self-monitor his furosemide therapy in such a way that he maintains a target weight that we've ascertained is 175 pounds. And we can go through a process of teaching him to self-titrate his furosemide therapy. That takes a whole bunch of different skills that we as pharmacists have. I didn't name anything there that we are doing for this person that is outside the scope of what pharmacists are trained to do. Not everyone is doing this all day, every day. I don't get to work in your practice, and so I don't get to know how representative these ideas are to your practice. But think of the analogous things in your practice that this does relate to in terms of assessing your patient and deciding what they need. And then the important thing is, of course, how are we going to follow up and monitor this patient so that we ascertain whether our therapeutic goals for him have been achieved. This is very, very old school thinking, very, very low tech thinking. I just simply challenge you to contemplate all of the patients that you've provided care to in the last week. Reflect on how many of those you explicitly said to yourself in that whisper of that inside voice, what are the goals of therapy for this patient in relation to this drug therapy decision that I just made? What are the goals of therapy? There's a thing that happens to us as we get older and as we get better at practicing our profession, which is that we rely less on that, what you used to disparagingly call book knowledge. Remember when you used to be able to remember all the side effects of prednisone? Remember that? And you worked really hard and you had your little flashcards and you were awesome. I remember you. And then you got into practice and you got really good at looking after patients and you just kind of went by feel. And you could just kind of feel that this person was having some slight euphoria due to that prednisone dose increase. And so you have all of these things happening to you that we all do as practitioners, all of these kinds of confirmation biases and ascertainment biases, and we remember that which we've seen, and we forget about those things that were on that list that you once memorized that you haven't seen in a while, and now your story about what a patient experiencing prednisone toxicity, your story looks like the collection of cases that you've seen that look like that, and it very much neglects all the other manifestations of that toxicity that you forgot about that you haven't seen yet. You feel me there? This is called heuristics. There's very little you can do to overcome this other than use discipline, which is keep reminding yourself of what that list that was very important to you as a trainee said. Because the heuristics, while making you a more efficient care provider, and we like to talk when we get old about how, well, I've experienced, like I can just tell that this patient's probably hypertensive. I can just tell by looking at them. I'd say they're probably 165 on 94. Hook them up, all right? So we take pride in that thing, right? Generally speaking, that does you some service. Experience is important. Generally speaking, all the sort of formal metrics of clinical skill, and this has mostly been shown in physicians, erode once your training stops, okay? And so you're not getting better with age. I feel like I should finish that sentence with some more levity, but I can't honestly. What we can do, though, is be disciplined and use the thought technologies and use the things that we were trained to do to overcome that sort of inertia and that fading into the background that happens when we go from knowing every possible adverse effect of lithium to not, to remembering that it has something to do with peeing too much and watch out for your sodium. Okay? This is all about goals of therapy in many ways, right? This is about, well, what am I trying to achieve here? Well, I'm starting my patient who's 165 on 85, and has hypertension and a history of coronary artery disease and is 45 years old and has a Framingham risk score of about 11%, because you're a clinician and these are the things that you do to look after your patients and assess them. And I'm giving them 2.5 of amlodipine. And then you move on to the next thing. And obviously being deliberate about what our goals of therapy are for that person, articulating those in conversation with the patient or their family, documenting somewhere what you were thinking. Well, what were you thinking when you started the amlodipine? Like, why did you do that? What was the point of that? Why didn't you just increase the dose of his metoprolol that he was already on, right? Goals of therapy is what all of that centers around. And so my low-tech thought technology to remind you of that you all learned about in pharmacy school, but that because of heuristics we tend to not think about in every decision that we make, is centering the ideas of what we're going to do for our patients around that. Monitoring your patients is not distinct from assessing your patients, and thankfully Sean Spina did all of the heavy lifting in regards to this earlier today. What we're thinking about, of course, is bringing the clinical skills that we have to our patients' care. And for many people, just from my talking to lots and lots of pharmacists, some of these ideas immediately raise senses of anxiety or needing to go to Langara. just ideas about, well, you know what, I don't know how to use a stethoscope, or I don't measure my patient's blood pressure, or I don't palpate abdomens, or I don't know, my patient says they think they might have pneumonia, but I just don't know how to bridge the gap between that and being able to say that it does sound like they have some, you know, left lower lobe consolidation there. These are all things that pharmacists are doing across the country and around the world every day, physically assessing patients, and so I'm not going to harp on that. A lot of what we're here for is about the future of pharmacy. The future of pharmacy will involve all of the things that are being talked about on the far end of the bleeding edge of the technology spectrum. In order for those things to be relevant, pharmacists, in my view, need to be doing a lot more of the low-tech things, and that is fleshing out and developing their willingness and their skills and their competence and their confidence in assessing what's wrong with your patient, and extending that into making good drug therapy decisions, which I have a lot of confidence in pharmacists to do, once they are armed with what's wrong with my patient. You have heart failure, so you need an ACE inhibitor. Well, do you have systolic dysfunction, the only kind of heart failure that ACE inhibitors help with, or do you have diastolic dysfunction, or do you have valvular dysfunction? Well, I don't know. Well, what would I need as a pharmacist to look at, or what would I need to ask about to ascertain the answer to that, to even know where their beta blocker and ACE inhibitor therapy are the appropriate ones? Well, I need to know what my patient's latest echocardiogram showed. Oh, okay. And I guess that'll just tell me? No, it won't. You need to know what things to read on the report about the echocardiogram, right, about whether they have valvular dysfunction. And so this is just what assessing our patients involves, and it is not out of reach or out of scope in any way for pharmacists. We all in the room have lots of different feelings about that, about whether that's what we signed up for, about whether we'd make someone mad if we acted like we knew that kind of stuff. Those are all things that we all have to deal with. I'm just here to suggest to you that developing our skills, and those are just some examples of very common things that our patients can benefit from having well-developed skills in regards to developing those skills in that area. These are the ways that we will expand what we're able to do for our patients and help them with. And for them to rely on us, therefore, once our patient JN there has had an individualized monitoring plan for his diuretic therapy that you and he have negotiated together, then you and he have a bond and an understanding and a relationship where there's an accountability that passes between you in the same way that it does for all the ways that we interact with our patients about, well, what's the goal here? What are we going to try to achieve? Okay, good. I want you to be having, if you're not having, instead of 4 episodes of diarrhea a day due to your Clostridium difficile by Wednesday, we need to talk about that. So I'm going to call you and we're going to talk about that. I'm sorry that you're uncomfortable talking about numbers of episodes of diarrhea, but that's the kind of thing that we're going to have a conversation about when we talk about that on Wednesday. There's a whole realm of skills that relate to interview assessment, and how do we talk to children, and how do we talk to the parents of children, and how do we talk to people who are demented? How do we talk to people that are demented but don't know they're demented? You know those people? These are all skills. There are bodies of knowledge that can help us to attain these skills, and nowhere is it more important than in pharmacists who interact with these people on the front lines all day, every day. Diagnostic testing, the whole laboratory interpretation issue. I think about this and deal with it enough in my practice and my research and that sort of thing that I just call it the lab tests issue. I know it's an issue for you because I know lots and lots of pharmacists who tell me that one of the major barriers to them doing these high-minded, low-tech things that Loewen's talking about is they don't have access to their patient's laboratory tests. I don't come here today with magic beans to fix that, but I acknowledge that needs to be bridged somehow, and I know oftentimes in patients that I interact with, the way that we bridge it is they go and access their own lab values and we talk about it, but I know in your practice you've figured out lots of other ways to do that. Low technology things, but they're now on your phone, are all the risk prediction tools and that help you to figure out what your patient's risk of having an MI over the next 5 or 10 years are, and therefore what your goals of therapy are that for them in terms of cardiovascular risk reduction, and whether they deserve statin therapy, or how worried you are about their hypertension and what your goal for their hypertension is and that sort of thing. All of these kinds of things are all on your phone and your MedMath and your MedCalc and your MedCalX and all of the apps that are designed to help you as a clinician have access to that on the front lines. Lots of your patients have atrial fibrillation. Many of your patients have strokes every year because of that. Lots of them are not on therapy that is well aligned with the risk of stroke. How do you know what the risk of stroke is? You Chads Vast them, or you Chads to them, or you go to sparktool.com and you look at my way that I try to help with that kind of thing. These are just examples of the kinds of clinical prediction rules that are not fancy and do not require anything other than that which you're carrying on your body all the time anyway. And then we can make smarter decisions. Curb 65, like my patient says they might have pneumonia, or they had a cold and they're worried it's turning into pneumonia. Well, how do you know whether that's happening or not happening? Physical assessment. Looking at risk factors, looking at their Curb 65 score. Check it out. Do you have any of these things? Oh, well, then your pneumonia might be severe enough that you need to go and seek emergency medical care, where they're going to definitely Curb 65 you and decide whether to send you home on oral antibiotics or admit you. When you get your patient who's been in emerge with it and they come to you with a prescription, if you work in a community setting, for, I don't know, cefuroxime or cotrimoxazole or something, do you know what their Curb 65 score was? Do you know what the severity of their pneumonia was? And you could. You could, because the things that go into the Curb 65 that are now going to become your monitoring parameters over the next 7 to 14 days while they're on antibiotic therapy are things that you can follow in them, and you can ask them intelligent questions that are actually very predictive of how their pneumonia is progressing or resolving. Beyond, well, how you feel? Like, are you coughing a lot? Are you producing much sputum, or is that getting better, or is it turning green? Guess what? None of those things are in Curb 65. None of those things are very predictive at all about how your patient's pneumonia is resolving. So these are examples of clinical prediction tools. Your patients on oral anticoagulant therapy, like zillions of our patients are. Many of them because they had a prior pulmonary embolism or venous thromboembolic event. And they come to you saying, you know what, my leg's starting to feel like that time when I had that, remember I had that DVT a long time ago? And I play hockey, and I bumped it. Like, do you think I'm having a DVT? Well, I don't know, you should go to Emerge. You could do that. Or you could look at the Wells criteria that are on your phone, in your MedCalc and your MedMath, and make a determination as to what the probability is that what your patient is presenting you with, that you can readily assess, is likely to be a VTE event or a non-thrombotic, a non-thromboembolic kind of a complication, that kind of stuff. These are patients on anticoagulant therapy. So in case any of you are thinking that's fancy talk and I don't diagnose things, your patients are on oral anticoagulant therapy, you are their drug therapy resource, so this is what we monitor. How do we know if their anticoagulant therapy is working? Is that someone else's job? That's our job. And this is a way that we know whether it's working in a patient who's only on it because they previously had a DVT type event. Where do we monitor our patients? This is something that we're strategic about, and do we call them? Do we have them come back? Do we go to their home and have these conversations with them? These are all important decisions that we make. And then, of course, we berate our students about this all the time. It's fine to tell me that you want to measure your patient's blood pressure. I want to know exactly when, and how often, and in what setting, and this kind of thing. And so these are things I'm challenging you to think about when you say what your goals of therapy are, which I love that you're going to do in the coming days and weeks. Okay, well, when are you going to assess whether those goals are being achieved? Super low tech. All of you, I hope, learned that when you look at your patients, you do it in a head-to-toe manner, and that you think about these body systems as you're interrogating yourself about what all the possible side effects of prednisone are. So, I don't get to go through all of these systems and name all the possible ways that drug therapy can affect them, but you know them. The thought technology is to actually do this. And I know this is how our pharmacy students are trained nowadays. I know many of you are trained this way. And then we move away from it because heuristics. But the discipline of thinking about from an efficacy point of view and a safety point of view as we monitor our patients from a head-to-toe point of view, what's happening? Are we achieving the desired therapeutic outcomes, and is our patient experiencing any adverse effects? And then, of course, what is super routine is, from a monitoring point of view, is this thing working? Are we achieving our desired outcomes, our goals? Are there any safety issues that are arising? If there are, how will we anticipate them? Do we need to order a lab test to make a determination about whether that adjustment we made to the patient's levothyroxine in response to their TSH being 8, was that too much of an adjustment? And now have we made them hyperthyroid, even subclinically hyperthyroid, and they have atrial fibrillation, which they're telling us just recurred within the last week, coincidentally, when we increased their levothyroxine dose. These are all things that can be interrogated by looking at a lab test, but you'd have to know that that was something that was a goal of therapy, which was that we wanted to get their TSH between 0.5 and 5, and so we have to be proactive in actually monitoring for that. And so these are all things that pharmacists are expected to do, are trained to do. I say that just because I can read all the standards of practice, and I know what it takes to get a license, and I know how many of you were trained, not all of you. I mean, none of this is fancy talk through the lens of this is what everyone from a professional point of view has been saying pharmacists are supposed to do. By the way, this is what we, in many cases are promising the public and other healthcare professionals that we're doing. And so let's please be doing it. This is what we're training our entry to practice Doctor of Pharmacy students to do. So by the time they finish their program, and they're going to need your help with this, in this one parameter, we've got about 140 of these, but by the end of PY4, professional year 4, they will use physical assessment, interviews, diagnostic laboratory tests to perform assessments of the status of the patient, response to therapy from an efficacy and toxicity point of view, identify drug errors and needs for therapeutic adjustments in moderate complexity patients, and they will be able to adapt the assessment process to accommodate patient-specific needs, like language barriers, additional diseases, cognitive dysfunction, cultural sensitivities, physical disabilities, etc., in a flexible and efficient manner, responding easily to changing patient needs and acting appropriately in the face of uncertainty and ambiguity. This is what I spend lots and lots of my time trying to do, trying to be this as a clinician and trying to help our students get to the point where they can do this, because this is how we as a, when I wear my university hat, this is what our students have to be able to do for our program to be considered a accreditable Doctor of Pharmacy program. So I just remind us all of that for context. If for those who decide someday, if all goes well, to become a certified pharmacist prescriber, you have to do this. You have to monitor your patients and document and follow up and be specific, okay? Just a last little thought bubble is about adherence. A good many of your patients are not doing the stuff that you're telling them to do. I think everybody kind of knows this, right? This is from just a couple days ago. The biggest study looking at this issue and it was looking at the United States from a hypertension point of view, and you've got somewhere between 20 and 40% of patients on chronic antihypertensive therapy who do not meet the criteria as being adherent. In other words, taking more than 80% of their doses at the right time and or taking them at all. So it's boring when people remind you that your patients are non-adherent. My belief is that there are things that pharmacists are probably the most responsible healthcare professionals in helping our patients to actually take the therapy that they're on. I resist, and I have a whisper in my head all the time when I talk about adherence, is I don't want any of my patients to be adherent to bad drug therapy that they shouldn't be on. So helping your patients stay on their drug therapy is you doing less than half of your job, because our job is to make sure they're on the right drug therapy. Once we get them on the right drug therapy, that's the only time that it really now matters that they be adherent to that therapy. You feel that? So just reminding and berating and annoyingly telling our patients to make sure they take that drug that's making them feel terrible and is way too expensive and is not actually an evidence-based therapy for the chronic management of their inflammatory bowel disease, that's not us doing our job. We should not be doing that. When our patients are on the right therapy, and that's the hardest part of our job, helping them to make sure that they use that therapy so that they are able to achieve their goals that we have co-designed with them is what it's all about. And so there's lots of evidence around how significant the non-adherence issue is. So males or females, one or the other, are way less adherent to chronic drug therapy than the other. Think about it. Who believes that it is females who are way less adherent than males? Who believes that it is males who are way less adherent than females? Okay. The evidence around this is absolutely clear that females are way less adherent to chronic drug therapy than males. It's not even debatable, okay? Men, we like to just do what we're told. We don't want to make a bunch of decisions. We just want people we trust to just tell us how it's going to be, and then we just go along with that. And I can't speak for what it's like to be a woman, but I guess it's not like that. Okay, so your female patients are not taking the drug therapy that you're acting like, oh yeah, well, right, I'm counseling you and you're doing this and how's it going? It's good, yeah. They're not doing it. They're not doing it. Okay, so this is really important. And so we need to be skillful in recognizing and caring about whether it's not my job to make you take it. I mean, I'm just telling you what to do. Like, you decide. Our patients will always decide whether they're going to be adherent or not. This is the deal, right? No one does anything that you tell them to do. They decide whether they're going to do what's being advised based on a whole complicated set of things that you all know, like, can I afford it? Do I care about the problem that this is here to treat? Is it convenient? Does it fit inside my lifestyle? Am I worried about the stigma of being on risperidone to help me sleep, when if someone sees that I'm on that, they're going to think I have psychosis? Myriad things, right? There's a whole bunch of things that decide whether your patients are going to be adherent or not. It's our job as healthcare professionals to use extremely low-tech emotional intelligence and clinical skill to be able to engage them and have conversations with them so we can actually ascertain what's actually going on and then help them. It may be that texting helps them, okay? It may be that there is a technological solution to this, or there may not be. Guess what the solution very often will be? Yeah, you're on the wrong drug. And did you know that there are ways that we can anticoagulate that mean you don't have to go and have your INR measured all the time? Your patients are lying to you about their health. So this is a nice study that was just reported on by a researcher in social work at UBC Okanagan, looking at elderly people who have recently been discharged from hospital, and they lie to their healthcare professionals about how they're doing and what's going on with them, okay? They lie for a whole bunch of reasons that range from they do not accept that they are sick. They don't want to be a burden to anyone. They're worried about being stigmatized as having disability. Some of them are just flat out in denial about what's wrong with them. So we cannot ignore the fact that these are occurrences that are happening in our relationships with our patients all day, every day, and that we have to be skillful in recognizing and being able to engage with them in ways that are authentic and meaningful and non-technical, but that are socially and aware and compassionate. There's a whole bunch of way smarter questions you can ask your patients about adherence than, are you taking your medication? Patients will generally lie to you about that. And then there are a whole bunch of way more skillful questions you can ask them. Like, have you ever cut back or stopped taking your medication without telling your doctor because you felt worse when you took it? Have you ever stopped taking your medication because you felt like the problem that you were taking it for had gone away? Like, well, my hypertension went away. You told me that, pharmacist, so I stopped taking the thing. Did you take your medication yesterday? These are way more skillful ways. This is the Mariski adherence scale that I just offer as an example of way more intelligent questions to ask your patients to help to get at their actual medication taking behavior than, do you take your medications? Your patients, If someone just asked you that, someone who is in a position of trust, not as trustworthy as a firefighter, mind you, but someone who's in a position of trust, and you're saying, yeah, no, I don't take my medications. Yeah, no, I usually forget. We have to get at the truth so that we can help people as much as possible. Okay, so I'm just going to stop there and invite you to look inside yourself and think about whether there's anything in any of these thought technologies that have arisen in this short period of time that make you think, well, I might do something different in my practice. I might decide to read up on a thing. I might decide to refresh my memory about what a head-to-toe approach is. I can think of a patient or a kind of a patient in my practice that might benefit from me being more deliberate in what the goals of therapy are for them and to act accordingly. My dreams would have come true if many of you were able to say that anything was different in regards to how you think about this as a result of our discussion.